In this lecture, we're going to review some of the basics related to the standards of exercise stress testing and some of the considerations to consider with exercise prescription. Now, in terms of generating an exercise stress test, this is usually conducted approximately a week or at least a week after a person has experienced a myocardial infarction. And the exercise stress testing is symptom limited, as opposed to the performance of the exercise, which is oftentimes used as the limiting factor to stopping a test. Now, an important note to make here is that the attending physician will make a determination as to whether an exercise stress test should be conducted, because there are contraindications where a person engaging in physical activity will be placed at a greater risk for experiencing another severe MI. And the whole point of exercise stress testing is to essentially assess the degree or the extent of the myocardial ischemia. And this stress testing is often conducted in conjunction with any type of imaging technology or the use of sound waves or echocardiography to get these images of relevant parts of the heart that may or may not be receiving an adequate blood flow. And the first type of test is referred to as a pre-discharge exercise test. And the endpoint here is driven by a sub-maximal effort. And so this particular test is carried out to ensure that the assessment of physical capacity and to determine if there are any other necessary medical procedures that have to take place with the submaximal effort is going to be carried out. So the submaximal effort is sufficiently enough to determine if the treatment for the patient should be extended beyond any sort of conservative therapies. And although we won't go into any of the details for these other types of stress tests, the important point to note here for the vast majority of these tests, which are carried out essentially to evaluate the degree of ischemia or the development of symptoms, is that these are all symptom limited maximal efforts. And so individuals here would normally present with a rather limited exercise capability, but the important point to note is that if any of the symptoms of angina develop, that is the criterion in which the exercise test will be, the procedure will be terminated. Now, in terms of exercise prescription and exercise training, the same principle of individualization applies here, and probably even more so, because individuals here will have a range of not just different types of conditions, but severity of these conditions. And so this has to be individualized. But there are other limiting factors that must be considered as well. These are what I call the reality factors. And so some of these limitations to consider are limited to what's called outpatient supervised exercise. And so some individuals may have employment obligations that would interfere with their ability to participate in some form of exercise training. Some individuals may not have reliable transportation to the rehabilitation center on a regular basis, and out-of-pocket expenses is one very realistic factor that may limit a patient to participate in a cardiac rehabilitation program in an outpatient manner. But the exercise training, if it starts with an inpatient approach, the goal here is to stimulate patient mobilization, just to get the patient moving as soon as safely possible. And the goal here is to try to avoid prolonged bed rest, because prolonged bed rest may actually interfere with recovery and further return to function for the post-MI patient. And we want to prevent physical deconditioning that would naturally occur with prolonged bed rest. And this begins with uh, active range of motion exercises. And so these exercises can be performed in a lying or seated position, uh, but in a more functional, once the patient proceeds to a more functional type of task, involves sit to stand exercises and short distance walking, while keeping in mind any development of symptoms that may arise with any of these exercises. And the other goal here with inpatient cardiac rehab is to prevent secondary coronary issues. And so measures to prevent any further development if it's been diagnosed of atherosclerosis. And that prevention education not just extends to the patients, but also to the families. And some of this education involves the preventable factors that would contribute to cardiac disease. And this includes avoiding tobacco, modifications to the diet. Going back to one of our earlier videos here, try to pay attention to the 3 S's: the salt, sugar, and saturated fats, and try to gain better control of blood pressure, as well as circulating blood lipid levels, which require monitoring on a more regular basis. And in doing so, the return to daily activities is the ultimate goal, provided that it's done in a relatively safe manner. Eventually, with a successful inpatient approach here with cardiac rehabilitation, that would transition the person to an early outpatient. So the person is no longer residing in the hospital. They've been discharged to their home, but they're making regular visits back to the rehabilitation center. And this occurs within 1 to 2 weeks of discharge. And the overall goal here is to encourage exercise independence, because statistics do show that the utilization of outpatient cardiac rehabilitation is quite low. It's actually less than 20%. And so these are very underutilized services that post-MI patients are able to take on. Table 14.3 summarizes some of the details here for training of the cardiorespiratory system, the musculoskeletal system through resistance training, and basic and simple range of motion exercises. We won't go into this in any great detail, because if you take a look at some of these guidelines here with frequency, intensity, you see a very wide range of frequency, anywhere from 3 to 7 days per week. Intensity is gauged by the RPE scale, if using the RPE scale, and this is the Borg 6-20 scale. And so holding cardiorespiratory intensity anywhere from 11 to 16, or 40 to 80% of exercise capacity. And this goes back to our previous slide that indicated that exercise rehabilitation and training must be individualized. And so that's where we see a rather wide range. The one notable pattern with all of these prescriptions is that it's typically performed at a relatively lower degree of volume and intensity than what we would normally see in terms of typical exercise prescription for a non-pathological population. And this keeps in mind that this particular population will have a relatively low physical capacity, particularly those that are post-MI. So this ends our final lecture on part 2 of acute coronary syndromes.